Okay, we'll get into full screen. So this is your guys' third review for maternity. And this week, the exam will cover complicated high-risk pregnancy, a complicated high-risk labor and delivery, medications, and math. So complicated high-risk pregnancy we'll start with first. We'll start with diabetes mellitus and gestational diabetes. So risks for these include preeclampsia, early delivery, neonatal hypoglycemia, and more. So those are things that it could potentially lead to. The difference between diabetes mellitus and gestational diabetes is the point in time of diagnosis. So gestational diabetes is diagnosed around 20 weeks of pregnancy, and it's diagnosed by a fasting blood glucose greater than 95 milligrams per deciliter. This is controlled mostly with dietary changes and an increase in their physical activity. Rarely will there be a need for supplementary insulin, but sometimes there is. Moms typically return to a pre-diabetic state after delivery, and they do need a 6-week postpartum check-in on this to make sure that they're back to a stable, normalized, their blood sugars, all of that. So important to know, poor glycemic control during pregnancy can lead to congenital fetal anomalies, and that's why it is so important to get a good grasp on it and get their blood sugars under control. So with this process, there is a progressive resistance to the effects of insulin. This will lead to an increase in maternal blood sugar and the need for insulin replacement therapy is usually in about 20% of women. So the increased fetal insulin production, they produce this on their own. So this becomes a problem once baby is birthed because they become separated from the placenta, and this is why it leads to the high risk of neonatal hypoglycemia. So does that make sense to you guys? So mom has that circulating maternal glucose. So this makes baby's own insulin production increase as well, but then when she's separated from the placenta and no longer receiving that circulating blood sugars of mom, baby's blood their blood sugars immediately drop to an unsafe level. The other complications that it poses to babies is macrosomia, because the extra circulating glucose leads to fatty deposits in the fetus. Let me know if I'm going too fast, as always, guys, okay? So HIV positive pregnancy. So the best thing you want to do is educate moms who are HIV positive on the need to adhere to antiretroviral drugs. This is the best way to reduce their viral load in circulation. HIV is transmitted through bodily fluids. You guys are probably pretty well versed on this at this point. But it is imperative to educate them that if it's detected, that they start, or if they've known about their HIV, that they continue treatment regularly to reduce the chances of transmission to the fetus. Treatments for this are AZT, so Retrovir. This is an antiretroviral drug, and if they have early treatment during their pregnancy, mom will potentially be able to breastfeed and will potentially be able to have a vaginal birth if the viral load is low. Okay, Hyperemesis Gravidarum. Isabel, you want to take this one?
Right, so Hyperemesis Gravidarum, that is excessive vomiting throughout the duration of the pregnancy, and it's not to be confused with the, kind of normal signs of the symptoms of, or it's not like, some pregnant women will have vomiting and a lot of nausea, but this is like excessive vomiting, even past that first couple weeks or months of pregnancy. And the cause of this is high levels of that HCG hormone and estrogen. And of course, like, if someone is vomiting multiple times throughout the day, there are going to be some complications, like decreased in weight, dehydration, and with ketosis and acetonuria, which is just like an excessive amount of ketones in the urine. So priority for these moms who have this hyperemesis is to make sure that they have enough fluids, and to check their electrolyte imbalances, make sure there's no imbalances there.
Nice, good job. Okay, so molar pregnancy, this is a benign growth of sperm that have replicated, and it is not there. These moms are not, they're not moms because this is not an actual true pregnancy with an actual fetus. This is a very rare condition. Patient education for these women is that they need to abstain from conceiving in the next year. And they also need to have regular check-ins and evaluation for the potential of cancer development. It is important that they have a good understanding of this, because there is that risk of the cancer development. Other interventions for these women is emotional support, because they were under the impression that they were carrying a child, that they were going to have a true pregnancy and a true baby at the end. So this could be really detrimental to these women, and just offering them that emotional support using that therapeutic communication is really important. Okay, ectopic pregnancy, similar but different. This is a true pregnancy, but it's in a state where it will not develop to an actual fetus because it's been implanted somewhere outside of the uterus. So implantation occurs outside of the uterus, and that could be anywhere other than the uterus. It could be intramural, it could be cervical, ovarian, it could be abdominal, but it's most likely going to be within the fallopian tubes here. That's the most common area that we see. I think about 95% of those you're going to see there. Patient education for these women. You want to inform them that their chances of conceiving again are reduced. It's going to be more difficult for them, but it's not impossible. Treatment for this, if it's in an unruptured state, we give them the methotrexate medication, and that will pass it basically. This is a medication that's generally used for RA, rheumatoid arthritis, and it stops the cells from dividing. This is the non-surgical method to terminate an ectopic pregnancy. If there is a rupture of an ectopic pregnancy, this is a medical emergency because it would cause major internal bleeding, and we need to advise them to get emergency care stat. Cervical cerclage. So this is related to the shortening of the cervix or premature dilation. It is the sewing up of the cervix to prevent miscarriage or premature delivery. The goal with cervical cerclage and this intervention is to get them to 38 weeks gestation so the baby can fully cook and there's no premature delivery of the baby. We want to also inform them not to be doing any heavy lifting and being on bed rest as much as possible as well. Okay, preeclampsia. You want to take preeclampsia as well?
Yeah, I'll take it. You can add anything if I forget anything. So risk factors for preeclampsia is diabetes, also chronic hypertension if they've had hypertension pre-pregnancy, and kidney disease. So kind of like chronic versus preeclampsia is when they have the hypertension and the other signs and symptoms, which is usually proteinuria, that will be preeclampsia, versus chronic hypertension is when they have had hypertension before and then they have it again. It continues during pregnancy. So signs and symptoms of the preeclampsia is, of course, the big one is, you know, an elevated blood pressure, usually over 40 systolic. Also, the proteinuria. They can also have edema in their extremities. It also causes low blood perfusion to their tissues. Some severe cases, they will have blurred vision, severe headache, that right upper quadrant or epigastric pain, which is related to those elevated liver enzymes. You can also have altered mental status, and the pulmonary edema, as well as liver and renal abnormalities. So because of that, if you have a patient with preeclampsia, you'll be wanting to check those liver function and renal labs, as well as checking if they have any crackles too. So just knowing these signs and symptoms of preeclampsia is very important, and knowing which ones are more severe, like the blurred vision, the severe headache, and that abdominal pain. Diagnosis for preeclampsia, it's usually made after 20 weeks, and they'll have that elevated systolic blood pressure, usually over 40, and the proteinuria. Those two things are usually the most commonly signs and symptoms to diagnose the preeclampsia. A worst case scenario and severe case of preeclampsia is called HELP syndrome. And it's a good acronym to kind of help you remember what's going on. So you have the hemolysis, which is the destruction of the red blood cells. You'll have elevated liver enzymes and low platelets. So you have the HELLP. So especially with the low platelets, you want to report that number to the physician, because of course that's very serious if they don't have enough platelets. And there's also a high risk for seizure activity or eclampsia. So if a patient has, has a seizure, the protocol for that is to stay with the patient and call a code. You never want to leave that patient because, there's always risk for falls, risk for injury. And patients who do have that severe hypertension, you want them to be on bed rest, and you want to give them hypertension medications like hydralazine and labetalol, and as well as IV magnesium sulfate. Other complications that can happen with preeclampsia is the abruptio placentae, which is when the placenta kind of like tears off of the uterus. You can have organ damage as well as cardiovascular disease. Those are the more serious ones.
Did great
Do you
job.
want to add anything?
You did great. The only thing I want to say is that I don't know if it dropped out where you said systolic above 40. I heard, I believe that's 140, right? Because 140 and higher is going to be like a really high systolic.
Yeah.
I don't know if it dropped out or what happened. So yeah, guys, think high blood pressure, right? And the ones that we start getting concerned about. And then that's just like even more of a load on mom when she's carrying a baby. Good job. Okay, so placenta previa. So this is a low-lying placenta in the uterus, which may cover all or part of the cervix. The hallmark sign of placenta previa and how we differentiate it from abruptio placentae is it's going to have painless bleeding. So typically, moms with placenta previa will need a C-section. We do not want the placenta coming out before baby, being birthed before baby, because that means that baby's still in the birth canal and they're not receiving the nutrients, the oxygen that they need to, and that puts baby in a high risk state. So if it is a complete previa, meaning that complete or total over here on the right, where it's covering entirely, you do not start the oxytocin. If there is an order for oxytocin in mom's chart, you're going to question that if she's got a complete or total placenta previa. If there is a suspected placenta previa, you want to prepare for an ultrasound to figure out where that placental location is, figure out which type it is it marginal, partial, or total? You want to be looking at the labs for hematocrit and hemoglobin. You want to be getting ready fetal heart rate monitoring equipment. The different types, again, are marginal, where it is just that low-lying placenta. It's not really covering or coming into the site of the cervix. These babies may have a chance of performing a vaginal birth. It really is it's going to vary depending on the physician and what they feel is justified in the case. Some may be like, okay, they'll advocate for the patient really, really wanting that vaginal delivery, but some will be like, nope, we're not doing this. Like, it's too risky. And other factors come into play. For partial or total placenta previas, these will most likely end up being a cesarean. Total definitely is going to be a cesarean, just because it would be way too high of a risk of the placenta coming out before baby. For abruptio placentae, so this is when the placenta detaches from the uterine wall, trauma is the most likely cause. So car accidents, domestic violence, abuse, if they've fallen down the stairs, any blunt trauma could lead to abruptio placentae. This is a high rate of mortality for both mom and baby. Signs and symptoms include, or the hallmark sign for this one is going to be that sharp abdominal pain. Treatment is to get that baby out as soon as possible, immediately. If there is a category 3 fetal heart rate monitoring tracing, this is absent variability plus late decels. This is an emergency C-section, and they're going to be rushing mom and baby in to get baby out stat. Different types of abruptio placentae include marginal abruption, partial abruption, and complete abruption. And this is just the degree of how much of the placenta has detached from that uterine wall. And then also the bleeding, whether it's external bleeding, concealed bleeding, that can vary between the different types as well. Okay, anaphylactoid syndrome and amniotic fluid embolism. This is a medical emergency. This is, you want to know what signs and symptoms to catch early enough. So if they have a sudden decrease in their blood pressure, if you're detecting crackles, shortness of breath, those 3 are major indicators of amniotic fluid embolism. And these could lead to cardiovascular collapse and DIC. Which is basically bleeding out. It's disseminated intravascular coagulation, and basically it's a disruption of the clotting factors and they bleed out, and it's a very serious condition and medical emergency. So the second you start noticing, these types of signs and symptoms, I'm really passionate about this emergency acute stuff. If you guys can't tell, I find it very interesting, and but this is a medical emergency, get them help right away. The priority intervention with cases like this is you're going to get O2 on them immediately on a non-rebreather, which could also be termed as a tight face mask. And you're going to start oxygen at 8 to 10 liters per minute. That's important to know. Fetal demise. You want to take fetal demise?
Could you guys go back one slide for just like 10 seconds? I just
Yeah, of course.
one thing.
Let me know if you guys have any questions.
8 to 10 liters. Okay. Thank you so much.
Mm-hmm.
So fetal demise. I don't know if you guys saw Chrissy Teigen's post from a few months ago, last year, I think. It was, she was pregnant and she lost her baby during the pregnancy. And it was like, I don't know about you, but I was like crying while I was reading the post. It's super sad. So, a fetal demise is also known as a stillbirth. It's the birth to the fetus after 20 weeks of gestation. As a nurse, our priority interventions is to really give supportive care for, the parents or whoever the support system is. You have to give the opportunity or give the parents an opportunity to grieve, whether that means, letting them hold the baby or, see the baby, spend time with the baby even after the baby has passed. And also offering chaplain chaplain services, which is non-denominational, and it can help, um, you know, accept it. It can help, give clarity to the situation. Another thing too that hospitals do offer sometimes is you can do like the handprint or the footprint, and hand that off to the parents, and just offer those services and see if they want it or not. But it's mostly just giving supportive care during this time for the parents.
Yeah, good job, Isabella. I'm not sure who you were referring to, but yeah, I actually had a friend. This happened to her a couple years ago, and it is a very devastating event. I just want to note on it is also known as stillbirth, but we don't use that term anymore. In the hospital setting, we use fetal demise when we're talking about this. Yeah, it's very sad. Okay. Complicated and high risk labor and delivery. So preterm labor, this is when contractions begin before the delivery date. In particular, the cervix is effaced and dilated to 2 centimeters. That would constitute preterm labor happening. Magnesium sulfate will aid in the cessation of preterm labor for about 48 hours, but also tocolytics will aid in stopping and decreasing labor, and this can help baby cook in utero just a little bit longer. Betamethasone is definitely going to be given right away. It's just like almost like as a prophylactic in case premature birth is imminent anyways, and it's going to happen regardless. This will help babies' lungs develop in utero a bit more expeditiously, basically. And it's important we get that on board so that there's a better chance of survival for the baby if they're born prematurely. If a mom calls and they're saying that they have increased vaginal discharge, pelvic pressure, they're having lower and abdominal back pain, you want to let them know to go to L&D triage at the hospital as soon as possible. This could be indicative of preterm labor or perhaps another complication that could be happening, but either way, they need to go get checked out ASAP. Okay, medications. You want to take medications? You want me to take medications? There's a lot, so it's up to you.
I can go for it. Okay, so there are a good amount of medications for pregnancy and birth, and they're good to know. Especially you'll see a lot of Pitocin, and the dinoprostone, also known as the Cervidil, and those are for post-term pregnancy induction. And then the misoprostol is for fetal demise induction. So the dinoprostone or the Cervidil, it will be removed or taken out if contractions reach a frequency of 1 minute. And that medication or that the dinoprostone helps to dilate and open the cervix. Pitocin, as you guys all know, it it helps with the contractions and gets the contractions going. Some adverse effects for Pitocin is the uterine hyperstimulation, which can cause a sudden decrease in the fetal heart rate. And it can cause, severe lower abdominal pain with a tearing sensation, and the abnormal fetal heart rate. So when we see those things in a mom, we want to suspect possible rupture of the uterus, especially with that tearing sensation, and that would be considered a medical emergency. You want to intervene immediately. And also, if there is a significant decrease in the fetal heart rate, you want to stop the Pitocin immediately. That just means it's like it's too intense, the contractions for the baby, and the baby's not responding to those contractions well, or it's not allowing the baby to recover after the contractions. For the hydralazine, as we said before, it's given for preeclampsia. So we just want to know, like, is that medication working? We want to be taking mom's blood pressure often, and we are hoping to see a decrease in blood pressure, and that indicates effectiveness of that medication. With magnesium sulfate, it is given for severe preeclampsia, and the priority for this medication is to monitor the vitals, the deep tendon reflexes, and if the patient is becoming excessively thirsty. So if we do see a variation in those things, we want to discontinue the magnesium sulfate immediately. Another concern with the magnesium sulfate is after delivery. There is a risk for postpartum hemorrhage because magnesium sulfate, it kind of like relaxes the contractions from happening, and as we know with postpartum, we want those contractions to happen to bring the uterus down and to prevent the bleeding. Other signs and symptoms of magnesium
Side effect.
sulfate. Sorry. Other side effects include cardiovascular complication, breathing difficulties, flushing of the face, and confusion. And those are indicative of magnesium toxicity, I believe. Another medication is the methotrexate, which is given to a woman who has an ectopic pregnancy that will terminate that pregnancy. And then the last medication is the Retrovir, which is given to mom if she is HIV positive. And that's just to decrease the viral load and prevent transmission, to lower the transmission possibilities from mom to baby.
Great job. You did wonderful. All these medications that are bolded here, guys, know them. They're bolded for a reason. Okay, prolapsed cord. So this just means the cord is below the baby or presenting part. Risk factors of a prolapsed cord could be a long cord, transverse lie or breech position, an unengaged presenting part. So that's like where the head is not dropping down into the appropriate staging. And this could be due to a head pelvis disproportion, especially if mom has a small pelvis, and depending on, how far along the baby has become, maybe the head has gotten too big to descend down, and that would be a risk of the cord dropping down below that. Also, spontaneous rupture of membranes could be a risk factor for a prolapsed cord. Types of prolapsed cords include occult, which is hidden. I think we all know at this point that occult means hidden. We have it in many different medical terms. In front of the fetal head, and also a complete or protruding prolapsed cord where it's coming out of the vagina as it is here. Interventions for prolapse cord, you're going to get mom's knees to her chest, you're going to elevate her hips, and the ultimate priority is you're going to use digital pressure, your fingers, on the presenting part of baby to take that off of cord compression. Once you have your fingers on there on baby's head lifting off of the cord, they're staying there until baby is coming out. So you're rushing into your C-section and baby's going to be taken out because you do not want to compress the cord further because that puts the fetus at serious risks, right? Shoulder dystocia. So shoulders have a hard time passing through the pelvic arch after the head has been birthed. This is an emergency situation. So a clock is going to be started. It's emergency and timely. And they're going to use McRoberts maneuver, which is suprapubic pressure and having the woman's thighs shot back upwards at her, like in a sharp angle, while they're using that pressure to try to get baby's shoulders to go out underneath that pelvic arch. It's very, very successful a lot of times, but if it is not, then a C-section will be warranted. Okay, other possible delivery complications. So we want to determine if a mom is attempting a VBAC. Do you guys know what VBAC is?
Vaginal birth after cesarean.
Yeah, very good. Vaginal birth after cesarean. So moms who have delivered in the past, they had a cesarean, which you guys, like, everyone says, you know, it's just a C-section. C-sections are hard. It's way more of a recovery process. And then it's also like taking away emotionally, like from the mom feeling like they were able to naturally give birth. So that's like something that's really hard on moms. So for those who are attempting this VBAC, the most important thing that we can do as nurses is you have to determine ahead of time what the previous incision that they used was, because it could be different depending on what country they delivered in. But if they have one of those vertical incisions that was used previously, they would not be a good candidate for a VBAC because this could be a risk, a very high risk for uterine rupture. Postterm and placental insufficiency. So if a mom states that she's only felt the baby move in the last couple hours, this is an issue. It means that the baby is not in a good state and further assessment is required. And ultimately, they're probably going to be getting that baby out pretty quick. For diabetic moms, during the delivery process, it is imperative to be monitoring their blood sugars very carefully and keeping them within a very solid range for blood sugar checks. If there is, again, tunneling back to the beginning of this review, if there's that increased circulation of blood glucose for mom, that puts the fetus and baby at that high risk of neonatal hypoglycemia when they are ultimately delivered. So monitoring those very frequently, if they're at risk for that, is very important. Okay, practice questions. I'll take that first one, Isabella.
The client is diagnosed with gestational hypertension and is receiving magnesium sulfate. Which finding would the nurse interpret as indicating a therapeutic level of medication? Is it A, urinary output of 20 mLs per hour, a respiratory rate of 10 breaths per minute, deep tendon reflexes of 2+, or difficulty in arousing?
You guys can answer in the chat. Got a few C's. 3 C's. Isabel, how many participants do we have today?
Right
Just curious.
now there's 19, not including us.
Right, so for those of you who answered, great job. It is the deep tendon reflexes of 2+ because that's a normal finding. We worry about magnesium toxicity, and the other ones are indicative of magnesium toxicity, whereas the deep tendon reflexes are good. Good job. Okay, the nurse is reviewing the laboratory test results of a pregnant client. Which one of the following findings, oh, shoot, you guys don't look. Trying to move the screen. Okay. Which one of the following findings would alert the nurse to the development of HELP syndrome? So A, hyperglycemia, B, elevated platelet count, C, leukocytosis, or D, elevated liver enzymes. And if you saw it, don't answer. Leave it for those who didn't see it, perhaps. Sorry, guys. Good job. HELP syndrome is an acronym for hemolysis, elevated liver enzymes, and low platelets. So this was like a little bit of a tricky one because we really harped on the platelets, that we were talking about, and could have just been thinking, oh, platelet count. Yeah, that one. No, it's low platelets. And we are going to report low platelets immediately to the healthcare provider if we detect that. And then the other ones are not part of HELP syndrome. Good job. You want to take that one as well?
Which of the following would the nurse have readily available for a client who's receiving magnesium sulfate to treat severe preeclampsia? So just think back to your electrolyte lectures from J2.
Yeah, we already got a couple smarty pants in there. So A, calcium gluconate, B, potassium chloride, C, ferrous sulfate, or D, calcium carbonate. Give it like another 10 seconds for some more responses to come in. Okay, so for the two of you guys that answered, yes, it is that calcium gluconate. Great job. This is the antidote for magnesium sulfate, and it should be readily available if the woman is showing the signs of magnesium toxicity, signs and symptoms. This will not be a medication on your exam, but it is helpful to know this for the HACI. Good job. Okay. A nurse suspects that a pregnant client may be experiencing abruption placentae based on assessment of which of the following, select all that apply. So which is going to be present with this condition? A, dark red vaginal bleeding, B, insidious onset, C, absence of pain, D, rigid uterus, or E, absent fetal heart tones. So we have A and E from one person. Let's get more than one response. We have A, B, E. think about how she's going to be presenting with abruptio placentae. Think about what causes it. Okay, we have a few ABEs. FYI, no one's gotten the right answer yet, so give it like another 30 seconds. There it is. Good job, Megan. Yeah, ADE, because it's not insidious onset because it's usually like an acute condition, like it detaches from that uterine wall, right? And that's usually in most case scenarios due to trauma, right? And so that's an acute, quick onset. Also, if they're in pain, they're going to have that rigid uterus because they're going to be guarding and having like that uterine tone there, basically from the pain. And then obviously, because the placenta has detached from the uterine wall, it's not receiving those nutrients, everything that it needs to get to baby. So absent fetal heart tone, so the placental insufficiency is going to be present. Does that make sense for those who chose the B option? And I think that was the only incorrect one. Cool. Okay. There will be one math question on this exam, and it's going to be very similar to this. So the physician has ordered a magnesium sulfate loading dose of 6 grams IV stat for a patient that is experiencing preeclampsia and preterm labor. The nurse has decided to run the loading dose over 20 minutes. How many mils per hour would the nurse set the IV flow rate on the pump at given that the medication supplied is 6 grams per 250 ml, premixed by pharmacy? Record your answer to the nearest whole number. So dimensional analysis. I'll give you guys like, yeah, take your time doing this. I'm going to give you guys like, let's say 3 minutes. Do you think that's good enough, Isabella? Yeah, we'll give you guys 3 minutes. Go through the math. Yeah, John, oops. Give it one more minute, you guys. Okay, anyone else want to throw in what you got? Oh, jeez. Deb got what? Okay, you got the same, and then I'm going to scroll back, and there is the math for you. So, John, you were on the right track when you said 18, but you had to like look at the question in its entirety, and it was asking for that the rate basically. So 18 grams would be given in an hour, but then you have to use dimensional analysis to convert that to the IV rate. Yeah, you jumped ahead. So just make sure with the dimensional analysis math type questions that you read them in full, especially with HESI, NCLEX, any of that, because they can trip you up like that. But great job with your math, and it is the 750 mils per hour is the rate. For those who didn't get it in time, and we're maybe working on it and maybe close, was this the right direction you were going and it feels good to you? Or do you want to talk about it some more? I just want to make sure it makes sense to you guys because only Deb and John answered.
And do you guys know why it was 6 grams times 3? Because when I first looked at it, I was like, oh, why are we timesing by 3?
Well, because you're doing it in 20 minutes, so you're doing it in a third of an hour. You're not doing it in a full hour.
Yeah, exactly.
Just in case.
And then for dimensional analysis, setting it up, it can be confusing to people. You always want to start with your dose desired, and then you're going to multiply that by the actual concentration, but you want to make sure that you flip the numerator denominator so it reflects what you're going to cross cancel out, right? You want mils over hours. So that's why you flip the 250 to the top. For anyone that's struggling with that, does that make a little bit more sense? Dimensional analysis can be confusing, so I just want to make sure you guys are good on this. Yeah. Awesome job. Okay, guys, that's it. Good luck. I know you guys will do wonderful, and you guys make me proud every week when I see your exam scores, so great job. You're doing great, and you have 1 week left. We have one more exam review after this, so go study, and you'll do wonderfully. I'm going to go ahead and stop the recording.